Thank you, Carla, and thank you, Anders, for this great opening. It's great to hear indeed about the child protection results. And as Carla has said, there's a lot of very good information in all different reports. Colleagues, I'm going to do a few introductory remarks on Goal Area 1. And one of the exciting features of the strategic plan, of this strategic plan that UNICEF developed with partners, is the way that Goal Area 1 was put together to bring together all of the different elements that need to be working in conjunction so that every child survives and thrives. And so, unlike the previous report, we put together a goal area that brings together health, nutrition, HIV, and ECD with very strong links to goal area 4, which has the work on WASH and a healthy environment. And I think this is an example of the recognition that in order to achieve some of these objectives, we really need a multi-sectoral approach. It's not just that all constituents have to be rowing in the same direction, but you need to be working across sectors and across systems. Some of these systems are obvious. So when one thinks of every child surviving and thriving, one automatically thinks of the health system as being such an important platform for interacting with children, their families, and communities. But I think it's also important to note that we're increasingly working across a range of systems. So, for example, our nutrition colleagues are increasingly involved with a set of partners that are looking at how food is produced. And so the whole issue of food systems and what food systems reinforce in terms of dietary habits, what food's available at affordable prices at the right places at the right time through different systems, I think is a profound determinant of children's health and nutrition and well-being. And so that's another key system that we're working on. There are several others. I'll mention a third, and it's not so much a system as a practice, which is the importance of parenting and work on parenting. And that's such an important part of engaging with families and communities. And so through the different sections that UNICEF works with, there's a point of contact with parents, and none more than with our early childhood development work, where the importance of both having both fathers and mothers engaging with their children from a very age is critical, but also supporting parents. Increasingly, as both parents are working, we are examples of this. You need systems and structures that can support parents to be parents as well. So exciting, important areas of work that we're engaged in. And I look forward to a very good discussion this morning. We're having a session that essentially goes from now until 10:55, focused on goal area 1. And what we're proposing to do is to focus first and foremost on health and nutrition. So if I can call our colleagues Luwei and France to come up, as well as our colleagues Chewe and Chemba, who will be looking at HIV and ECD after the break. Come up, colleagues. We look forward to a very good discussion. What we'll do before the coffee break is look at health and nutrition, do them back to back, then open up to a set of questions and answers, have a coffee break, then look at HIV and ECD, and that'll take us through 11. Look forward to good engagement, to good questions on this very important, exciting area of work. Please think of some of the questions that you might want to ask and engage on. And remember, this is about surviving and thriving, taking the child to their full potential from 0 to 18. Thank you very much, colleagues. Come in, please. So what's the setup again? Are the colleagues supposed to be sitting on those chairs, and how would you like us to go?
Yes, we have a little issue with the sound right now, so it's better than speaking that high.
Okay.
And then
We'll do the presentations first.
yeah.
We all sit on one side. There while the presenter is speaking. Why not?
Good morning, everybody. I am Luwei. I'm deputy director of health here. In the last 4 weeks, I have spent Sorry, I have to stand here.
Everyone online.
Okay, sorry. This is Luwei, and I'm the Deputy Director of the Health Program in New York. Last month, I was fortunate to spend 2 weeks in West Africa, 1 week in Mali and 1 week in Sierra Leone. I have seen how UNICEF staff, together with government and the partners, some of you are making tremendous difference in the field in the extremely challenging and complex environment. Today, I will go over some of the key results of the health program achieved. We produced 4 simple brochures for you to take away. They are light and easy to communicate. First of all, this is the first year of last year was the first year of the strategic plan. We are still quite focusing on the unfinished agenda in terms of child survival. Newborn deaths in 2018, 2.4 million, plus infant and child deaths, plus the many uncounted stillbirths, resulted millions of a child from preventable causes. It is common causes that can be prevented either from vaccination, from good care at health facilities or home, and these are unnecessary deaths. And on top of those common causes, we are increasingly dealing with injuries, non-communicable diseases, and the children suffering during outbreaks such as Ebola, measles, and cholera outbreaks. And we realize how important it is to strengthen the health service delivery platform and the primary health care at the front line. So the 4 key results areas that I will go through with you, they are in the areas of maternal, newborn and adolescent health, in child health, in immunization, and strengthening primary health care systems. In maternal newborn health, during 2018, we are able to achieve all the results we wanted to achieve that in our plan. We eliminated maternal and neonatal tetanus in Kenya. There are 13 more countries to go if we want to get rid of the disease globally. And 90 countries have been able to track what they do in newborn care in the government system. And we are scaling up adolescent program, health programs through multiple sector interventions. In immunization, we continue our great performance to try to reach every child. We reached 65.5 million children with DTP3 vaccines. We immunized nearly 20 million children with measles in humanitarian settings. And we dealt with vaccine preventable disease outbreaks. And very importantly, not just for vaccination, through strategic procurement services, with through the UNICEF Supply Division, we made a tremendous saving of over $350 million just by cheaper vaccines at affordable price for countries. Child health, we helped countries to treat 5.5 million children with pneumonia, and 60,000 community health workers were helped to deliver quality services. We provided bed net in humanitarian settings, and supporting community health systems performance, deliver services at the front line is a critical element of the program. Primary health care celebrated the 40-year landmark at Astana. And we looked at the lessons we learned in the last 40 years, and with partners and government, we wanted to really strengthen primary health care as the foundation to achieve universal health coverage. In 2018, we learned many lessons, and we want to use those lessons to inform our future programs. I've mentioned the importance of health systems at the front line, focusing on primary health care, and continue to focus on equity, reach every child, no matter where he or she is, and strengthening community systems, and engage private sectors and other partners, and in both urban and rural settings. Global thematic funding, the liquid gold, is rare for the health program. We only had just over 1 million out of the total 14 million, which is quite limited. We really want to appeal to your support to strengthen our partnership in the health programs so that we can achieve higher coverage and quality of services for every child. In particular, we want to thank the Luxembourg US Fund for their support. What do we want to do in 2019 and beyond? While we continue to deal with the unfinished agenda in child survival, we want to also look into growth and development, look at what we can do better in the areas that affect many more children, such as disability, such as NCDs, and introduce new vaccines such as HPV, and continue to deliver better with your support in countries. Thank you very much.
Good morning, everyone. I'm very happy to present the results of the nutrition report on behalf of nutrition. I'm France Bégin, Senior Nutrition Advisor. We know that nutrition is really a key input into several of the Sustainable Development Goals, but also it is a key outcome. And under the Sustainable Development Goal number 2, member states are really called to eliminate hunger, achieve food security, and improve nutrition. So it is in this context that the nutrition programs in nutrition aims to really contribute to ending all forms of malnutrition, which is one of the key targets of SDG number 2. We still have a lot to do. The numbers are big in terms of children who are affected by stunting, by wasting, and even children who are now overweight. While we may rejoice ourselves because there is a decline, important decline in the number of stunting over the past years, we still have to accelerate much more our efforts if we want to reach the reduction by 40% by 2025 for stunted kids. And we can see that there's been an increase in overweight, while the aim is really to not have any increase in childhood obesity. In the next few slides, I'm going to present the results, which are articulated around 3 main results: the prevention of stunting and other forms of malnutrition, the treatment of severe acute malnutrition, and the adolescent nutrition and health. Two main outcomes that we have on prevention of stunting and other forms of malnutrition are the contribution of UNICEF to provide vitamin A capsules. We're the main provider of vitamin A capsules globally, and we managed to reach 255 million children with 2 capsules per year, which is a key child survival intervention. We also have reached 15 million of children with vitamins and minerals, what we call the micronutrient powders, which help improve the diets and reduce anemia in those children. In terms of those indicators that we got, the output and GIT indicators to contribute to the prevention of stunting and other forms of malnutrition, we have 49 countries that have reported to have national strategy to prevent stunting. This means that they have adopted a strategy, but they also have implemented nutrition-specific interventions at scale. One important way to also reduce stunting is to improve the dietary diversity of children's diet. And we have 32 countries that have reported to have such programs. This means that they would have a combination of interventions, which include promotion of fortified food, for example, complementary food, use of local nutrient-rich food, better nutrition education activities linked with better parenting, improve stimulations and feeding, and linked with social protection. And lastly, we have a program that is quite new with UNICEF on the prevention of overweight. We have 17 countries that have reported to implement program to prevent overweight and obesity, which would include policies like regulation on marketing of food, unhealthy food, health-related taxes, and so on and so forth. Around treatment of severe acute malnutrition, 4.1 children were admitted for treatment with a very important recovery rate of 82%. But what is more important is the number of countries that have reported to have programs, treatment of SAM integrated in the health and nutrition services. This is absolutely key if we want to be able to detect earlier the children who are suffering from acute malnutrition, and if we want also to draw more resources locally. We have also a new program on adolescent nutrition and managed to reach 58 million of girls and boys with nutrition services, obviously recognizing that a big proportion of this number comes from India. The next 2 slides are some of the lessons learned we have for 2018. So we know that prioritizing prevention really works, but we need greater investment because it will not only help prevent stunting, but also even help prevent wasting as well as prevention of overweight and obesity in children. We also have seen that SAM treatment can really be integrated into routine services, but there we need also to do much more to work with governments to convince them that it's not an emergency issue only. In fact, we have much more children who are affected by acute malnutrition and severe acute malnutrition in development setting, but yet we have this impression that this is not the case and it's more an humanitarian situation. So much more needs to be done there. Adolescent nutrition can really be taken up to scales. We've reached already many millions of adolescent girls, but what we need to do to reach out also the out of school, we need to rely much more on the community platform, social mobilization platform to reach these adolescents who are not going to school. And we also know that global partnerships can really catalyze changes where in some areas where it's slow. As 2 examples here, the Global Breastfeeding Collective that is co-led by UNICEF and WHO with more than 20 partners, drawing more attention on the importance of breastfeeding, not just as a child survival intervention, but as a child development intervention. And the No Wasted Life Coalition, which brings many partners together to really put the management of severe acute malnutrition as a public health priority and helping mobilizing more funding to achieve that and providing more support to those countries. In terms of the fundings, we're glad to see that we've had more spending in 2018 than the previous year, but a big reason for this increase is for the funds that were earmarked for emergencies, given the bigger scope and needs for humanitarian situation. We were also very fortunate that at the beginning of our strategic plan, we received a great contribution from the government of Netherlands of 56 million to help us support the following areas here on improving children's diet, prevention of overweight, improving nutrition of school and adolescents, the maternal nutrition, and treatment of acute malnutrition. So a good set of intervention throughout the life cycles. So this flexible funding has allowed us really to improve, to be more strategic in our planning, help us to accelerate some of the results, and also allocate resources in areas that are usually underfunded, like improvement of the dietary diversity, the diets of children. We also know that it's good value for money because by supporting interventions that are low cost with high impact, like breastfeeding and micronutrients and promotion of nutrient food, we will also make a great contribution. And the focus is also on reaching the most in needs, which also had an equity lens to this investment. For the next year, for 2019 and the next few years, we have those goals that have been, those targets that have been set by 2021 to reach 250 million children under 5 years with services to prevent stunting and other forms of malnutrition, 100 million adolescents per year reach with services on health and nutrition to prevent anemia and other forms of malnutrition, and 6 million children under 5 reach with services to treat severe wasting. So we have 6 priorities that have been identified. We know that if we really want to make a dent in reducing stunting, we need to do much more on improving women's nutrition. And we have released a report recently jointly with WHO showing that 15% of the newborns are low birth weight, and so it's increased the risk of mortality, but also if they survive, the risk of undernutrition. We have the copy of the report at the back if you're interested. Improving dietary, the quality of diets of children is absolutely key if we want also to reduce stunting. So we will continue to work on that, not just to reduce stunting and prevent stunting, but other forms of malnutrition, including overweight, which is increasing. The nutrition of school children has been quite neglected, and we know that it affects their health, their learning capacity, and their potential. So we need to really synergize and use better the education platform to deliver nutrition services to those children. We also know that adolescent nutrition is an area that we need to take really this forward to really take this window of opportunity of growth and development. And we aim to reach to have adolescent nutrition program in 15 to 20 countries. Prevention of SAM, as I mentioned, is absolutely key, and making sure that it's earlier detected, and with that we work with partners to scale up those plans to reach to treat many more kids by 2021. And lastly, a systems approach is really essential to improve nutrition. We've worked with the health system. We will continue very much to work with the health system. We need to go beyond, as Ted mentioned. The food system is key to improve the environment, social protection to making sure that we have better access also to right services, and water and education and sanitation, which is also absolutely key in this regard. I thank you for your attention, and thank you also for your support.
Thank you very much, Luwei and France, for those 2 presentations. I really wanted to emphasize a couple of the points that came up. We will, in September of this year, have a high-level meeting here in New York that will focus on universal health coverage. And it's going to be a very important milestone in terms of how the world is dealing with health issues, and indeed the whole spectrum of issues around surviving and thriving. But I think one point that's been made that's critically important is that there can be no universal health coverage without a focus on primary health care. We had essentially a child survival revolution between 1990 and 2015, which focused greatly on primary health care. And it's so important that we continue to have an opportunity to invest in that system and maintain the momentum around primary health care. And that's a point that Luwei raised. Secondly, I really want to focus on the way that the nutrition folks are really looking across a range of systems at dealing with under but also overnutrition. And I think what's critical and what I find really exciting in the strategic plan is the way what UNICEF's trying to do with partners to bend the curve on stunting and wasting in particular has a direct correlation with what the world is doing in terms of trying to achieve the SDGs. And you can see a direct correlation between the two, and I think that's extremely important. Lastly, both emphasized, as I think we all have this morning, the importance of working with partners. There's so many partners that it really takes everyone rowing in the same direction to support countries to move forward. But in this regard, and in these two fields in particular, there's so many important global program partnerships that are key. The Global Fund, Gavi, we're all part of these consortiums, but they're a critical vehicle for moving forward with some of the results. With that, we have about 25 minutes for Q&As, and I hope you will hit the ground running with some questions. We have a number of experts. Perhaps we can ask some of the members who just joined the panel, in addition to France and Luwei, to introduce themselves.
Thank you, Ted. Good morning. I'm Rafael Obregon. I lead the Communication for Development section in the program division. And for those who may be unfamiliar, Communication for Development is a core organizational strategy that focuses on promotion of healthy and protective behaviors, demand for inclusive services, engagement and empowerment of communities, including adolescents, and in engagement of affected populations in humanitarian situations. Looking forward to the discussion.
Hi, good morning and welcome everyone. My name is Robin Nandy. I'm the Chief of Immunizations in the Health section.
Good morning and welcome. My name is Ruth Situma. I'm a nutrition specialist working on maternal and child in humanitarian context.
Thank you very much, colleagues. As you do take the floor to ask questions, please, if you could, or make comments or anything you'd like to raise, if you could introduce who you are, and we will take the questions in the order in which you raise your hand. As you think about your questions, let me actually put a couple on the table myself, if you don't mind, to get us primed and ready to go. Robin, one of the questions that's struck us is that when it comes to immunization and vaccines generally, we've seen kind of steady progress, but also somewhat of a plateauing. And now the issue of measles outbreak is in the news all the time, and not just in kind of countries which may be fragile or conflict affected, but even in high income countries or pockets of those countries. So it'll be useful to hear from you a bit more about immunization. Again, we'll take a series of questions and come back to you. And then Rafael, I think the issue of demand, which you have highlighted, I think is key, not just for every child surviving, but also thriving. If you could comment a little bit on the thriving aspect, that'll be very helpful. Colleagues, the floor is open. Please don't be shy. And is there a mic going around or not? Yeah.
No, but because we have the same issue, if you could repeat a little bit the questions.
Okay.
One or two, and then
I
we'll
shall
do
do
it.
that. Very good. Thank you. Please, go ahead.
Hi, everybody. I'm Barry Seeger. I'm the Chief Development Officer for UNICEF USA. For any of the panelists, so our main role for UNICEF USA is engaging the private sector. So whether you're talking about foundations, companies, individuals, they want, what we're hearing is companies, individuals, they want to be more than just funders. They want to be partners in our success. So when you think about the private sector, how are you thinking differently around your engagement of the private sector, whether it's a company, a foundation, or even an individual major donor? They want to be thought leaders with us. How can we work better together?
Thank you, Baron. So colleagues, bear with us as there's a number of people online. I've been asked to repeat the question so that the people online can hear, because otherwise, even with the mics going around, we're not going to have full participation. So the question asked from the U.S. Fund for UNICEF is, how do you see the private sector differently engaged in moving forward and achieving results for children? They want to be not just donors, they want to be partners. So whether it's a company, foundation, or individual, perhaps comment on the whole issue of private sector engagement. Thank you for that. Let's take 2 or 3 more questions and then we'll turn it back to the panel. Yes, please. In whichever order. Go ahead. Thank you.
I'm Raquel from Innovation Nations.
Can you raise your voice, please? Thank you.
Very pleased to hear and for all facilitators for the presentation. Specifically, I would like to ask for the primary healthcare, the community platform in primary healthcare. I heard that there is a community health roadmap in 6 countries. I would like to know further on this. It's very interesting for us to know more about the roadmap and the progress on the ground. Why these countries, these 6 countries, were elected to be the project. Thank you very much.
Thank you very much. And then one more, please.
I'm Roger, and I'm the chair of this initiative. And I would like to ask about maternal nutrition, because I think when we're talking about the child nourishment, and especially the babies, the small ones, if breastfeeding should be successful, is a question about the mother during pregnancy and after that they get it's something like that. So I just wanted about some specific examples to show us when a bit successful in trying to reach the goal by others.
Thank you very much. So, colleagues online, we had a question from the representative from the Indonesia permanent mission, and his question was he'd like to hear more about the primary healthcare approach, and he, I think, specifically referred to 6 countries that were highlighted in the presentations and why they were chosen. This may have been related to a specific source of funding, but I think it would be interesting to hear more broadly about our primary healthcare approach. And then we had a question from the chair of the Swedish NATCOM, and the question was about maternal nutrition and the links with child nutrition, undernutrition, and where have we been successful in supporting better maternal nutrition in order to, first of all, take care, support women better, but also because of the impact on child nutrition and breastfeeding. So, colleagues, a number of questions on the table. I propose that we go to the panel now as perhaps a second set of questions are prepared. Maybe, why don't we start with Ruth? There wasn't anything specifically on emergencies this time, so why don't we start with France and work backwards that way? France.
Thank you, Ted. With regards to the maternal nutrition question, so this is also a quite new area for UNICEF. What we've done in the past was to distribute iron folic acid to women during pregnancy, but we know it's not sufficient, and it's important to be able to detect them earlier during pregnancy, to be able to provide the right counseling in terms of food to be consumed, to ensure that there's also some rest. And so we have now a few countries that have indicated interest in working in women's nutrition. We have India, for example, that is doing much more with supplementary feeding for these women, because we know it has going to have an impact on their home pregnancy and on the birth outcomes, obviously. And this is so work in progress. I have a colleague also in the room, if we have a minute, that she could also say more about the work that we've been doing in this area. But as I said, recognizing that it's been absolutely essential, this is now a new area for us to work on. One way also to reach them is through fortification of food at large scale, which you don't need basically to then promote any changes in the behaviors and what they should consume, because this is food that they would buy at the market, and if the food is fortified, they would get also this way the right micronutrient for them.
France, before you turn the mic over to Luwei, and you kind of already have touched upon, the whole issue of fortification is with the private sector.
Yeah.
But to Baron's question, could you perhaps
Yes.
elaborate a bit how the nutrition field of work is engaging with the private sector?
Yeah, thank you. So that was the second point on private sector engagement. So we do recognize it's absolutely key to work with the private sector if we want to reach the outcome. I think nutrition has done already a lot because we work with food industry to make sure that fortification of key staple foods is fortified. That those staple foods are fortified with the right micronutrients to reach the populations. We have also worked with some of the companies to make the environment where women work more conducive to support them if they want to breastfeed. So we have already a few examples right now with garment industries in Bangladesh, with the tea plantation in Kenya as example. Absolutely understand that with the private sector there's a need also to see to be more like what we can do together, not just see them as a funder. And I think the work that we've already started with those examples was really like what can you do, how can we work together to improve the situations of women, of children in this case. And we will continue to do so in the future as well.
Robin, immunization.
Robin, okay, but you want to take the PHC question, Luwei? Yeah.
I can take the PHC question. The countries are prioritized based on the opportunities on the ground and the government leadership and need. And if there are more resources, we should really do more countries. Ideally, we should work with every country to improve the PHC and the community health system. Just to add one comment on the maternal nutrition and the low birth weight babies. When I was in Sierra Leone last week, I saw that UNICEF has supported 4 districts to set up special baby care unit to take care of those preterm babies and babies at high risk. And we're planning to do so in every district. And these days, even in West Africa, where the health system is the weakest, nearly 80% of mothers give birth in health facilities. So they are reaching the facilities, but the quality of care for both maternal and newborn care is limited, and we're working on that. And we hope you're going to join us to make it a reality.
Thanks. Yeah, thanks, Ted. Thanks for the questions. I'm actually going to start off with the segue from what Luwei just said and respond first to the question posed by a colleague from Indonesia. I did spend 4 years with UNICEF Indonesia, and just to say that our work on a particular project may be limited to a number of countries, but we have been working in the area of primary healthcare and community healthcare in a large number of countries, including Indonesia. We have a history of, through child health, supporting pilot programs for community management of childhood illnesses, working with the community midwives, your Bidan Desa program, working to improve the referral systems between the community to the health center and then on to the hospitals. And I think the point that we are trying to stress here is the primary healthcare system is relevant for every country on the planet. And this is where we want to get to, as we support countries realize their goals. Ted, your question is a very important one. And I've had a lot of media interviews around the measles outbreaks over the last several weeks following World Immunization Week. And, the first thing to say is that if somebody had told me that I would be sitting in 2019 talking about measles outbreaks in all sorts of countries, not only low-income countries, but middle-income countries and high-income countries, I would have been very disappointed. And I think, why is this happening? Yes, immunization coverage is stagnating, but we have to remember that each year we are vaccinating more and more kids. There are more kids that are being born in this world. So even though the coverage percentage is stagnating, we are vaccinating more and more kids each year. We're just not able to reach the most difficult to reach, which tend to be either in remote rural locations, in conflict-affected areas, or sometimes under our very noses in urban slums. And I think it's important that we target our strategies accordingly. We have also been victims of our own success. The relatively high vaccination coverage means that we had successfully eliminated measles from the Americas, for example, and this may have led to complacency on the side of the service provider, thinking that the job is done, from the side of the communities because they don't see the diseases anymore. So I think these outbreaks serve as a reminder, not only for immunization, I must add, and not only for health, but measles actually picks up the unvaccinated so effectively that we can safely say that a child who's unvaccinated for measles does not have other health or social services provided to them, whether it's nutrition, wash, child protection, education. So I think we all need to do that. And on the immunization front, I must thank everybody also for the support that you provide through the global funding mechanisms like Gavi and the Global Polio Eradication Initiative, which we basically use our resources in complementary to that. Private sector, very briefly, we have a long history again working with private sector. In immunization, we work with all the vaccine manufacturers and drug manufacturers in the broader health system. Foundations, we have a long history of working as thought partners. Gates Foundation is a primary one, but then we have long-standing relationships with entities like Rotary for polio eradication, Kiwanis for maternal neonatal tetanus, and so on. And then you have the private providers, which is extremely important, in the present day and age, which we are increasingly. Again, this is an area of growth for us. We are looking at working with private providers through professional associations and so on. I think.
Thank you. Maybe to
Can I just add something on
Sure.
the private sector, please? Just came back from Africa and realized their need on the skills of those countries in maintenance, routine maintenance, and the repair of critical vehicles, cold chain, essential supplies. The private sector provides a lot of pieces, but we need to work together to maintain those important and sometimes quite expensive life-saving equipment. And we can work with youth to enhance their skills. We can work with women to improve their capacity. We can learn from the private sector how they are managing the supply chain and logistics. There are a lot of things we can do together.
Thank you. Actually, before Rafael speaks, let me just say, Robin, to your question, to your point on measles, I mean, part of the issue, of course, also is educated, relatively affluent populations that are influenced by vaccine hesitancy. And so it's critical that there be a dialogue at all levels of society with all sorts of populations as we move forward as part of the solution. And that's a nice segue to Rafael speaking about the whole demand side of the equation. Over to you, Rafael.
Thank you, Ted. That's exactly right. I think that if you look at the presentations that the college has made, on every one of those issues, social and behavioral aspects are critical to facilitating access, demand, adoption of protective and healthy behaviors. So for us, in communication for development, then we place huge emphasis on engaging communities, facilitating a dialogue with those communities, and trying to find joint solutions to addressing those issues. And that's been a critical aspect of UNICEF's success in child survival over the years through water and sanitation interventions, nutrition, health. And as we move into greater focus on demand issues, certainly our efforts on engaging those communities need to be intensified. And communication for development provides wide range of platforms that we can leverage to strengthen, for instance, our focus on primary healthcare. If we look at what we have done in different countries, Bangladesh, South Sudan, India, many others, those networks that C4D facilitates at community level through women's groups, youth organizations, school-based groups provide entry points to facilitate that dialogue, to facilitate that engagement of communities. So I think we have a huge opportunity to leverage those investments, those platforms, to expand UNICEF's work at scale on these particular issues. And let me just make one more point on this, or two more points, which are very important from our point of view. One is that as part of that process, we also need to strengthen the capacities of those local networks, those local communities. They are often the frontline workers, for instance, when it comes to humanitarian situations or emergency situations. So by providing those capacities to those local communities and organizations, we are also better placed to facilitate local ownership and resilience when it comes to humanitarian situations. So again, when it comes to these demand issues, clearly those platforms that C4D has supported over the years become a huge asset for UNICEF work going forward.
Thank you, Rafael. Colleagues, it's 10:10. We might have a chance for one more question if there's one from the floor before we break. Yes, please. Thank you very much for that question. For the colleagues online, let me repeat, it's a colleague from Swedish SIDA who has basically asked a question about the links between this area of work and WASH, and specifically given the recent report on WASH in healthcare facilities, which showed that there are many healthcare facilities still around the world that don't have water and sanitation on the premises. Also ask about our work on antimicrobial resistance, and then obviously the links between that and the work that we do around cholera. Luwei, why don't we give you the floor to answer that question?
Thank you, Sida. WASH in-house facility is very important. It's part of the overall effort of quality improvement. It is not just water. We need to look at the basic infrastructure of the health facilities, not only for quality of care, but even just to retain healthcare providers in the facility. I have seen the effort of UNICEF and Gavi together to, when they provide solar panels to the cold chain with a little bit additional planning and resources, we solarize the whole health facilities. And in improving hand washing, and it's really important. And we want to work more in washing health facilities. It is a top priority for quality of care. So thank you for your support and comments. In terms of AMR, again, UNICEF has a clear strategy how to deal with the issue. It's not just to have single interventions. We want to start with prevention. Again, hand washing, immunization, good hygiene practices, clean environment would all reduce infection. When you reduce the infection, there's less chance that you need to rely on antibiotics. When it comes to antibiotics, we are aware there is both overuse as well as underuse. In many poor countries, children with pneumonia, newborn with newborn sepsis have not received effective treatment. Yet, there are children with simple diarrhea got IV drugs. So we need to balance the situation and work with the government to make sure that AMR is part of their national health sector plan. And we can have more exchanges to discuss more details. Thank you.
Thank you, Luwei. Let me just say that Carlos Navarro is here. He's the head of our health emergencies unit, and would be very happy to speak to you perhaps during the coffee break, both a little more about AMR as well as about the question you've asked on cholera.
Yeah.
Let me say that in all cases, what we're doing, we're about to issue our own paper on UNICEF's contribution to work on AMR and how we would support countries and government. It's very much, as part of certainly as part of the UN family, but as part of a network of partners. And I think, we're focusing, as Luwei has said, on where we can bring the biggest comparative advantage. In addition to the point she's raised, I would also emphasize again the point that Rafael has raised around the community dialogue, the effort around the demand side of the equation, and including public communication. So these are among the aspects. Colleagues, this has been a good discussion on Goal Area 1. Let me close by again emphasizing the importance of primary health care. To go back to our Indonesian colleagues' points, I can't overstress the importance of having a community health workforce at community level, paid community health workers, an emphasis, as Luwei has said, on different systems at work, including WASH in health facilities, as well as things like information management systems, supervision. I mean, we've actually had. I mean, literally, you can't call it anything less than a child survival revolution in the last 25 years. And, it really behooves us not to lose that momentum while addressing some of the emerging issues that the colleagues have spoken with. Undernutrition and overnutrition happening at the same time in the same countries. Issues of AMR, as you have asked. So I think this group of colleagues will be available during the coffee break. We have been generously given 10 minutes. So if you could quickly grab your cup of coffee, have a couple of comments among yourselves, and then come back for the second half of the presentation. Let me finally, as you get up, say, noted about getting the reports out earlier so that the colleagues can read them. And we shall endeavor to do better. But thank you very much. See you here in 10 minutes. Thank you. So in order not to be behind schedule, should we ask Cherry to come up? Come up, Cherry.
Thank you. And my name is Dr. Chewelo. I'm the Chief and Associate Director, HIV section. I'm going to go through the slides very quickly to allow time for discussion at the end. So let me see if I can work this. How do I move it up? Hang on. This one? All right. This one moves it. Right. I'm going to start with a bit of good news. The HIV epidemic has been with us for a very long time. And for some of us, we've been working on this, and UNICEF has been leading this effort since 2000 under the leadership of Carol Bellamy, at a time when we really felt it was impossible to address. But what I want to say is that both from the evidence base and also what we've been trying to do to actually translate that evidence into real action, especially where it's most needed, particularly Africa and other places, we've made huge strides. So the good news that I want to talk about is the scaling up of prevention of mother-to-child transmission. We know that if we deliver antiretroviral drugs to these women, we can basically curb the epidemic going to children. And currently, good news, 80% of these mothers globally, 1.4 million of them, are getting antiretroviral treatment. What that has translated to is that we've been able to avoid or avert 1.4 million child infections since 2010. And we continue to celebrate countries that are being certified by WHO to have eliminated mother-to-child transmission. Last year alone, we added Malaysia as the number 11 country to have been certified. The sad news is that in the most impacted countries in Africa, we have no country that has been certified. But the good news is that all these countries are really motivated. They are recalibrating their programs to see what needs to be done for them to be certified as having eliminated mother-to-child transmission. So this not so good news is that despite the effort in advancing treatment in mothers, we're not doing the same for children. And so the highlight here is that we continue to see mortality in children. That 130,000 is still a reduction from where we were in 2010, but it's one too many for children. And we still continue to see new infections 0 to 19, and the majority of those are 10 to 19. And I'll come back to that. So why is it that adolescents and children are being left behind is a critical question for UNICEF work in this area. So this just illustrates what I've already said. We're moving up on treatment for kids, but not fast enough. We need to get to that 90% coverage target by 2020, sorry, and then 95% coverage target for 2030. So that 52% for us is too slow, and we're asking the critical question why, although the mortality is coming down. Moving forward, as I said, we also have the prevention challenge. The good news is the world has come together through the Prevention Coalition that UNICEF is part of to actually ask the critical question what we're going to do differently for prevention overall. And for adolescents, we know that as we sit here currently, 250,000 adolescents are newly infected every year. And if we add young women to that, it's actually 430,000 of new infections. The reduction rate that we have of 3% per year is nowhere near where it should be. If we're going to hit that 75% reduction by 2020, we have to do something different. And so that's the focus of the UNICEF work, and I'll come back to that in terms of what we are prioritizing. So when we look at our outcome results, and then we look at our output results that impact those outcomes, we're not doing too badly. But as I said, the results for children I've already mentioned, 52% coverage compared to 80% of their mothers is nowhere near acceptable, and we need to change that. We have real issues with adolescents. We think that we're probably reaching about 30 to 37%, but the data is really limited, and UNICEF needs to step up to make sure that we get that data for adolescents. What you don't count doesn't count. So we know that that's important if we're going to curb the epidemic. You can't continue not to know what's going on in that population because the transmission cycle will continue, and we need to do something different. And then for mothers, I've already talked about the strides that we're making. 80% of them have access to treatment right now. Now, the outputs that we have in the SP really looks at what are the critical things we need to do to actually change the trajectory. And I think, you know, what we have in terms of the testing, UNICEF is really putting their dollar to say, if we don't test children, if we don't test adolescents, we're not going to get them into services to get what they want, both prevention and treatment. The second thing that we're focusing on this in this SP is really the rethinking what we need to do differently for adolescent prevention, including adolescent girls and young women. And the global solidarity that we're building around that is going to get us there, but it's walking steps in new thinking, new ideas and would like to partner with you on some of the thinking we are doing, including how we advance digital programming for this population. This population is not going to be found in clinics. This population is on the web. This population is well connected, but we're not tapping into that capacity and potential to make sure we do this. And we have good results from your report to tell us that these are very active people and you can reach them very quickly with a platform like your report. So in terms of recalibrating then, I just want to say the emphasis of the HIV program, we don't have much money in UNICEF, but what I can convince you is that the money we have is really to catalyze action and make sure that the money that we have in the HIV program, first, is focusing on children, and second, that they're investing in the right things to catalyze the impact that we want. So in doing that, the UNICEF approach, first of all, we have 35 priority countries that make up 80% of the epidemic, where we say we have to do a lot of work there to make sure that children are impacted. The second, the integration agenda is looking at us. UNICEF is well privileged in that we work multi-sectorally. What does that mean for HIV moving forward? And some of the things that the strides we're making, including the work we're doing in East and Southern Africa with CEDA funding, which is basically for women. It's an SRH program, but UNICEF is within that mix to make sure that we leverage that platform for adolescent girls and young women. The third is partnerships. What partnerships do we need to have the impact? For us, Global Fund is priority. How do we make the Global Fund money work? And we have good relationships with the Global Fund for adolescent girls and young women, using their investments and UNICEF coming in to provide technical support for that. And then innovation and knowledge is something we're also moving forward on. So moving forward, I just want to conclude to say, really it's about, for mother-to-child transmission, we need to continue the course. We need to ask the questions of what's going to make it difference moving forward. So we've coined the last mile for PMTCT with a huge focus on what we need to do in Africa, looking at the analysis we need to know where these new infections are coming from and what investments countries need to make. We're doing this virtually most of the time with the country teams to make sure that we can influence the resources that are coming into country. We are re-engaging on pediatrics, and there we're really looking at innovative approaches to getting to children. And you hear some of the work we're doing on point of care diagnosis, especially in Western Central Africa, where the systems are very weak and the labs don't reach children. So we can't test them. Only 21% of children in that region are accessing treatment. We want to change that paradigm based on the work that we've done in East and Southern Africa. So when we look at prevention, and I think there's a lot there, but one, there's a prevention coalition. UNICEF is leading the charge on adolescents and young women. We're also working very specifically with the coalition of partners around key populations and how we're going to find those young men that may be having sex with men. Very difficult to find. They're just identifying with themselves. What does it mean when we say we're going to reach out to those populations? Which networks are we supposed to look at? The second is that we have come to conclude that it's not about doing life skills, a bit of education, or a bit of social protection. It's about finding the locations where these children are located and what we need to do to layer these interventions so that we have more impact. So a lot of the work we are doing is really launching a much more comprehensive partnership to make sure that the children get what they need. And Lola can talk to some of that on the panel. But we can't do all this without money. You can see that chart for me is very sobering. We're only getting, I think on an annual basis, 28 million in terms of money that we can use to really have a global footprint on this. And it's very challenging because programs are closing out on us because we don't have the resources. And that's why we have to be smarter at how we use that 28 million. We distribute that money across the globe, and you can see that much of that money is going to Africa. It makes sense for us to have more investments there. And moving beyond, we still, I think from my conversation, we really need to prioritize prevention, especially for adolescents, adolescent girls and young women. We need to do something about infant diagnosis and linking children to care. In places like West Africa, I've said 21% of children are getting treated. And then we need to focus on elimination of mother-to-child transmission. And these are some of the priorities that we've highlighted. We're asking for $40 million a year for UNICEF to have a global footprint on HIV. This is a preventable chronic disease that doesn't have to impact children. I rest my case. Thank you. No, thank you.
Yes.
Good morning, everyone. I'm here representing the small but very aspirational city teams around the organization, global, regional, and country offices. I also bring greetings from the chief of the section, Dr. Priya Brito, who's not able to join us today, but our team is hoping to do full justice to what she might have also said to all of you today. We are, like I said, a small team. In the current strategic plan, we have 3 indicators, but I want to tell you a little bit about why we are doing those 3 indicators and why we are measuring along those 3 indicators. We had 3 global developments. The Sustainable Development Goal 4.2 on early childhood development gave us a very clear mandate and direction that we have to be working on early childhood development. So emphasis on the D, in ECD. The second, the Lancet brought out a series of very alarming figures. 250 million children around the globe, 43% of children under 5 in low and middle income countries are at risk of not reaching their fullest developmental potential. This should alarm all of us as UNICEF, as partners, as just parents, as community members, and as citizens of every country. These are young children. And the third framework that gave us very good direction on how we should recalibrate and work in our programming is the Nurturing Care framework that was launched with very key partners such as the WHO, UNICEF, and the bank. Talks about 5 components: opportunities for early learning, good health, adequate nutrition, security and safety, and responsive caregiving. These are all essential for developing young children into their fullest developmental potential so that we don't lose the 43% that have not yet reached their fullest potential. We also had huge mandate from the early brain development literature. I'm just going to talk about 5 key messages very quickly that we were told, and that should tell us how we recalibrated our program under the current strategic plan. The relationship between genes and environment is closer than ever before. So the whole debate of nature versus nurture is history, folks. It's about nature with nurture. It's about how genes interact with the environment. They provide the blueprint and the environment shapes it. So the environments of early childhood development for young children and beyond are very, very important. Message 2, timing matters. It really does matter. Some changes are very hard to reverse, and some changes are very difficult to address as the child develops later in life. Message 3, toxic stress during early childhood can have a lifelong impact. Experts tell us there are 3 kinds of stresses: positive stress, tolerable stress, and toxic stress. Positive stress could be what perhaps I faced this morning, that I'm going to face all of you, such experts. but it's all good because we're all sharing. So it has a good outcome. Tolerable stress is despite the rain. You all showed up to listen to these fabulous presentations of results that UNICEF has achieved. There is an outcome. It takes some difficulty, but we can achieve it. But toxic stress is the day in and day out, the things that children cannot, that families cannot seem to address, the environments of conflict, the environments of disasters, the environment of abuse, the environment of violence, the environments of urban slums that was talked about this morning. All of those can lead to toxic stress. Message 4, brain complexity is not homogeneous, but is interconnected. So changes in one part of the brain can impact other parts of the brain. We used to know structures. Now we have functional magnetic resonance imaging and so forth. And neuroscientists have taught us that we now know that when you change a little part of the brain, either with positive or with negative experiences, other parts of the brain can be significantly affected. So a child's brain is not going to wait to say, oh, you know what? Education sector will be providing me with something when I'm 5 years old. So let me wait for that. That brain has to work in an interconnected fashion. So it's really, really important that we do that interconnectedly. Message 5 is about nourishing the mind. It's nutrition. We've heard a lot about nutrition this morning, and the nutrition section here also addresses that very well along with us. And we work together to also promote responsive caregiving as outlined by the Nurturing Care Framework and promoting stimulation as well. So these were the big areas that directed us, to look at how we contribute to UNICEF's impact and outcomes. I'm not going to read those statements. So we have 3 indicators that we worked on in response to these calls from the global evidence. So we're a very evidence-driven group aspiring to do wonders with children. Number of countries that have adopted ECD packages for children at scale was one indicator. Number of countries with national ECD policy or implementation plans for scale up is another indicator. And percentage of UNICEF targeted children in humanitarian situations who participate in organized programs covering early childhood development. So on indicator 1, we're on track. Not only are we on track, we have exceeded the milestone for this year. So our milestone for 2018 that we set for ourselves was 16 countries. We have 33 countries with established systems. What that means is that there is government ownership and costed action plans ready to go for these multi-sectoral packages that are important to address all of those key messages coming from the Lancet and from the neuroscience and from the SDGs very clearly. 80 countries are actually ready to roll out. So 33 are established and 47 have emerging systems, which means governments are owning these programs, but are still lacking costed action plans. So our strategy is to move countries from emerging to established and from established to more advanced states of system maturity, because we believe that is a very good way to enhance health, to enhance safety, to enhance the early learning, to enhance the protection and the nurturing care that we talked about earlier. The second indicator, acceleration is seriously required, while number of policies and plans are enabling environments, and we really need those. We also need them to work in conjunction with the multi-sectoral packages that we're talking about. We've talked about toxic stress and why it is very important. This is particularly important to address in both humanitarian and developmental contexts. We have several examples throughout the report. I invite you to read them. I want to highlight that ministries of health and ministries of child protection are already working together in many countries. So in India, for example, the MCP, the Mother Child Protection Card, is ready to go to scale with the elements of responsive caregiving now added to address that brain development and early childhood development. In Thailand, our demonstration centers are supporting scale up, and there are a huge number of emerging initiatives, including plans and including responsive caregiving, training for staff, community health workers, and counseling. In Rwanda, we are ensuring the implementation of the early childhood development policy that's already there. And there are numerous other examples in the report. We also believe in communications, and the Early Moments Matter campaign really supported our efforts. In 2018, we leveraged collective action through the Father's Day campaign, which engaged over 2 million people in 125 countries, potential reach of 1.6 billion users on social media. With the support of the Lego Foundation, we launched the Parenting Hub. With the support of H&M Foundation, we launched Baby Talk for Dads. With H&M Foundation, we produced mini parenting masterclasses. Ted talked about the importance of parenting. We are really working quite a bit on that. And lastly, we are advocating very seriously for greater investment in family-friendly policies and support working parents to give their children the best start in life. So we've had a lot of lessons learned and challenges. Our packages are working. We are finding that C4D platforms are very critical for ECD results. We have huge technical challenges and other challenges. Articulating responsive caregiving and stimulation and capacity building for frontline workers in multiple sectors continues to be a challenge which we are trying to address. The absence of family-friendly policies in countries is something we're trying to address. Sustained political will and commitment is something we're working to address. And of course, the usual suspects of subnational implementation, technical capacity to be strengthened, suitable tools, metrics, etc. So we have a plan for how we can contribute to country progress. We can increase national and organizational capacity. We leverage sectoral delivery platforms to accelerate results and including ECD outcomes in health centers, in integrating stimulation, etc., in early learning platforms, in child protection platforms. Leverage partnerships and networks and strive for sustainable funding. Our high-level priorities for 2019 and beyond is to enhance support for parenting, advocating for family-friendly policies, articulate early learning more clearly as beginning from birth, leveraging ECD system strengthening and delivery, plans to include nurturing care, enhancing early detection and interventions, and increased and enhanced support to ECD in humanitarian settings. What we could achieve with additional flexible funding. I just want to point out that we don't have thematic funding. We really are looking for, we are spending about 1% of the total budget. ECD sustains itself primarily through other resources to supplement the limited emergency or regular resources that we receive. And against a backdrop of evidence, we heard a lot about catalytic effects. Our programs can also contribute to multiplier effects because they're working with young children, they're working with families, we're working with the private sector. So it can have a multiplier effect. Flexible core funding can support strengthening emerging systems to become more established and strengthening established systems to scale up and become champion systems. Thank you very much.
Thank you very much, Chewe and Chemba. We're a bit behind schedule. I think there's two lessons learned from the organization today. Firstly is get the reports out earlier, and secondly, there is no such thing as a 10-minute coffee break. So with the coffee break having put us slightly behind schedule, I will ask for forgiveness from our education and child protection colleagues that are coming up next, so we can have a couple of minutes for Q&As to our HIV and ECD colleagues. Let me also say that I think one big strategic opportunity is this issue of early learning, and it kind of straddles into the next section. I think Chemba has spoken about education and stimulation from birth, but I will hear next from our education folks on the whole issue of early learning, which I think is a key strategic priority. Colleagues, the floor is open for question and answer. I think we'll probably take two. And then we've been joined, perhaps if you could, if our colleagues who've just joined could briefly introduce themselves. Let me also note that we now have fixed our audio problems, so we have better sound with our colleagues online. They are also invited to ask questions, although perhaps for the next session more than this one, given the limitations of time that we have. Can you colleagues briefly introduce yourselves? And then we literally have time for a couple of questions.
Sorry, just for the online, we need you to sit there in the so that people online can see you. And you
so why don't you, Anna, do you want to go ahead and introduce yourself? Give the mic to Anna, please.
Good morning, everyone. My name is Ana Nieto, and I'm part of the Early Childhood Development team here with Chemba. Good morning.
Good morning, everyone. My name is Nada Ghattar, Early Childhood Development Specialist in Emergencies, part of the ECD team.
Good morning, everyone. I'm Lola Walker. I work in the HIV section on adolescent and HIV programming.
Good morning, I'm Alex Costa. I'm an HIV specialist, and I'm currently managing the point of care project for UNICEF.
It's each of them says their title, but they're like global experts in the area that they're talking about. It's amazing to have this kind of talent in the room sometimes. Colleagues, I'm afraid we are against the time limits, but please, if there's a couple of questions that people have, by all means, put them on the table. Floor is open. Go ahead, Baron.
Baron, Senior Chief Development Officer. Chief Development Officer, UNICEF USA. You mentioned men who have sex with men. The LGBT community, largely underground in so many of these different countries. What are you doing to change your strategies so that we're truly reaching the hardest to reach, to make sure that young people, adolescents who are underground in the fear of persecution, that they have the same access as others?
Thanks, Baron. One more question, colleagues? Nope. We'll give our ECD colleagues a 1-minute chance to say something at the end there because we rushed their presentation. Chewe, the question that was asked to you.
Thank you. I think that's a very important question, and it's one that actually makes us not sleep at night because it's very, very hard. I remember going to Malawi and my colleague there telling me that in the effort to try and do something in Malawi, UNICEF office now became the protection office for these young people, just because the country was not ready for that type of response. But I think what we've learned with the HIV program is that state is one thing, and we need to continue to work on legislation and policies. But we also know that the power of community, civil society in this type of context is extremely important. And we worry a little bit in the HIV program because with the diminishing resources, civil society voice and action is actually dwindling in a lot of countries because we're not funding them adequately. So we continue to work with these networks to make sure that they continue to fight for rights and work with us very specifically on some of these issues, but it's not easy. The second point that I want to make on LGBT is just the population we work with is dynamic. There's no such a thing in, when you look at children 10 to 19 and what they are starting to be faced with just because of their sexual identity, it's a very difficult thing for a child to even come out in the open. And then again, in those sort of situations, what we try to do is to work with the older populations to see how they can help us reach to the younger ones because they know who they are. And so our program in Thailand, for example, is trying to do exactly that. So it's about social networking of colleagues in the field and UNICEF then coming in to layer some interventions around that. I don't know whether, Lola, you want to say anything?
I think
I'll now make it quick. Thank you for the question. I think in addition to what Chewe has just highlighted, I think there is a specific entry point, a unique entry point that we can optimize as UNICEF when we look from the lens of child protection. For many of the LGBTI young children, 10 to 19, maybe even slightly younger, we see staggering rates of violence, physical violence, bullying. We see mental health issues, depression. When we bring the conversation to the communities and to governments from the angle of child protection, mental health, and well-being, we see an opening of a conversation and an opening of dialogue. And so it's something that we would like to advance within our programming, and we look forward to having further conversations with you on how we can sharpen our programming to address those specific issues.
Shemba, I'd like to let one of your team members perhaps add to your presentation and say if there's any angle they'd like to bring out.
So very quickly, because I know we're pressed for time, I just wanted to wrap up by saying that we are in very exciting times in the early childhood development field, because as Chemba articulated so well, the last 2 decades have focused on the why. We spend a lot of time introducing a lot of science, from economics to neuroscience, getting all the Nobel Prizes to actually endorse this. But now is the moment where a lot of governments are already convinced. They are on board, but what they want is the how. So I think the challenge for us here in UNICEF is really to accompany a lot of those countries that are looking for how do I improve my financing mechanisms? How do I make sure that I have better capacity building for my workforce? How do I create data systems that are able to tell me who is left behind and how can I actually address those specific needs of the most vulnerable groups? So I wanted to thank you all for coming here today, and I hope that you are here in the journey with us in the next decade to make sure that we are really making sure that all children not only survive but thrive. Thank you.
Just one last thing to add to that. Chemba very beautifully articulated the needs of young children, especially in humanitarian contexts as well, by talking a bit about toxic stress. I just wanted to emphasize that that's a very important point that sometimes is overlooked in terms of really looking at the overall developmental needs of young children in humanitarian settings and the need to strengthen capacity and programming in that space. Thank you.
Alex, anything to complete the panel?
On HIV or antimicrobial resistance?
Whichever you want to go.
No, I think in the context of HIV, UNICEF launched a program called Innovations for Scale last year. I don't know, my microphone is failing. Yeah. Speak a little. Yeah. So, the point of care project was for early infant diagnosis of HIV to increase access to diagnosis and treatment of infants has been approved, and it's currently being implemented in 10 Western Central Africa countries, which is the region with the second highest HIV prevalence, but it has been neglected in terms of HIV investments. So this is an innovative approach to really reach hard-to-reach populations and really try to shift the needle in the right direction and increase survival of these children.
Thank you very much, colleagues. Behind each of these presentations, there's a huge amount of work in those reports in particular, and these are the colleagues that not only support our work overall globally in these areas, but also contribute to that. I wanted to finish by both a plug, but also an emphasis on an area of work that we're going to be taking forward, which is the whole issue of support to parents. And all of the colleagues, I think, have emphasized the importance of parenting, and the heads of several UN agencies recently issued a statement on UN for family leave and childcare, and essentially making the point that both parents need to have the support and the room to be able to parent. So a call to increase the duration of parental leave to 24 weeks, to have designated nursing and pumping rooms available at work, to be able to provide and support childcare support for parents. When both parents are working, we're increasingly urban populations where both parents are working, and you no longer have that extended family, which we used to have. Even in my own childhood in Lebanon growing up, I had that extended family. It no longer is there. So you need an alternative to be able to provide childcare support, and really equal treatment and respect for all methods of becoming a parent, regardless of your gender, regardless of your sexual orientation. So I think these are important steps forward that the UN is trying to commit for itself to do. But I think also these are going to be important areas of programming for us to take forward so that countries can also move forward in these areas. So thank you very much to the panel, and thanks for all of you for having been such active participants in Goal Area 1. Thank you.